Hey everyone, we're going to get started. My name is Julian Perez. I am the Vice President of Risk Management and Compliance with dentalcorp. Joined here today by some very prestigious and generous guests who have agreed to spend the evening with us and to share some of the information and expertise that they have around the topics of research and COVID-19 and dentistry. So I'm going to start to introduce everyone and we'll begin our conversation. The first guest I'd like to introduce today is Dr. Paul Allison from the Faculty of Dentistry at McGill University. Dr. Allison gained his dental degree, a BDS, from the University College of London in 1986, then pursued specialist training in oral and maxillofacial surgery and dental public health. In 1994, he moved to McGill University in Montreal, where he completed a PhD. He became a professor at the Faculty of Dentistry at McGill in '99. He became the director of the Quebec-based Oral and Bone Health Research Network during the period from 2005 to 2008 and served 2 5-year mandates as the Dean of the Faculty of Dentistry at McGill. That's from 2008 to 2018. He was president of the Association of Canadian Faculties of Dentistry during 2015 to 2019. Is currently the president of the Canadian Academy of Health Sciences. He's also a member of the board of the Canadian Council of Academies, and he's on the governing council of the Canadian Institutes of Health Research. Dr. Allison's research interests include the psychosocial and social determinants of oral health and oral health care, including issues of access to healthcare. His research has particularly focused on groups with head and neck cancer, Down syndrome, young children, and other vulnerable groups. In 2014, he chaired a CAHS, that's the Canadian Academy of Health Sciences panel that published a report on improving access to oral health care. Most recently, he is the author in a Lancet series on oral health and has become involved in various COVID-19 pandemic research projects. Welcome, Paul, and thank you for joining us.
Thank you very much. That was quite a mouthful, but thank you.
We're also joined by Dr. Walter Siqueira. He is the Associate Dean at the University of Saskatchewan College of Dentistry and leads the Salivary Proteomics Research Laboratory, more of which we will hear shortly. Dr. Siqueira is one of the first and only dental clinician scientists in Canada conducting salivary proteome research. I hope I said that right. Dr. Siqueira's research centers on the biology and biochemistry of saliva, a critically important area of oral health research, and one that has become even more important with the interest, even obsession around the aerosolization of saliva during dental procedures. The initial stage of bacterial colonization of teeth is the binding of salivary components which form a pellicle to which bacteria subsequently adhere. And Dr. Siqueira's research employs cutting-edge proteomics to address this very early stage in disease pathogenesis. So these are things that dentists are dealing with on a day-to-day basis, whether or not we're in the middle of a pandemic. Walter's program is unique in Canada and one of only a few in the world. And it addresses the areas of salivary research and the development of non-invasive salivary diagnostic tests for oral and systemic diseases, which we're also going to talk about shortly. His studies are highly translational, involving both clinical research and human projects and advanced mass spectrometry approaches for characterizing the salivary proteome. And Walter can share with us how that's become relevant in our quest to find a quick and cheap and accessible test for COVID-19, and hopefully one that dentists will be able to employ in their practices not too long from now. Welcome, Walter, and thank you for spending the evening with us.
Thank you, Julia. Thank you.
Last but certainly not least is our very own Dr. Gary Glassman, dentalcorp's Chief Dental Officer and world-renowned endodontist, full-time practicing dentist, global lecturer, who is on the staff at the University of Toronto Faculty of Dentistry. He is the author of numerous publications and the editor for Oral Health's endodontic edition of their journal. He graduated from the University of Toronto Faculty of Dentistry. He's been awarded numerous scholarships and fellowships for excellence in endodontics. Dr. Glassman also serves as the faculty chair of DC Institute, dentalcorp's continuing education provider. which supports the growth and development of dental care professionals throughout Canada by way of an elevated learning experience. Gary, thanks again for joining us.
Thanks, Julian.
So our topic today is research, dentistry, and COVID-19. I'd like to start with you, Paul, Dr. Allison, if I may. In your bio, it says that you've become involved in various COVID-19 pandemic research projects. I've seen your name on some papers. I have seen emails come in from dental associations respecting surveys being done of dentists that I think are projects that you are overseeing or involved in. Can you talk to us a little bit about the types of research projects that you're currently involved in and how they relate to COVID-19?
Okay, thanks, Julian. So basically, as soon as this started, I reached out to quite a lot of leaders across the country to try and find out what dentists really needed and dental organizations really needed to know about to try and help them in this really, really difficult period. Because I wanted to try and help the profession from my home office, so to speak. And it became very clear that issues like, not surprisingly, infection control and how to deal with that sort of thing were very top of mind, but also things like teledentistry emerged as topics from across the country. And so having had discussions with professional groups and then with research colleagues, I then started embarking on a few projects. First of which was doing a simple survey of what was happening amongst dentists in Nova Scotia. With Nova Scotia, the board there agreed to participate in that. So we sent out a survey concerning their activities during one of the weeks in the middle of April. We just wanted to know what the activities were, what sort of care they were providing, how they were providing it, et cetera, et cetera. And we had a really good response for that. About 43% of all the dentists in Nova Scotia responded. So we've got some interesting results from that. Also became involved in looking at how to use teledentistry. And so we worked on an article that I think will be emerging quite soon, thinking about how we could use teledentistry both now in the pandemic, but also thinking to the future post-pandemic, whenever that may be. I think, personally, I think that teledentistry, telemedicine, telehealth has been underused in the field of oral health care for good reasons. But I think this gives us an opportunity to explore how to do it, how to use it, what we can do and what we can't do. And then what the big project that Walter and I are working on, that's received funding from the Canadian Institutes of Health Research, is a project to investigate infection rates among dentists across Canada. We are just about to launch this project, and we really want to, we'll be sending out messages to invite dentists across the country to participate, and we want to find out whether the infection rates amongst dentists of COVID is the same, higher, less than in the community. We also want to see what difference wearing N95 masks make amongst those dentists who are using them regularly, and also what difference using aerosol generating procedures regularly makes as well. So we're going to be following dentists, several hundred dentists that we recruit across the country for about a year, and analyzing the data every couple of months to try and see what information is emerging, because we are very aware that it's really important to get, as soon as we start to have these analyses ready and we have information, whether we see increased rates of infection, not decreased rates of infection compared to the community, or whatever we see, we need to inform the participating dentists, but also we need to inform the dental organizations, because obviously dentalcorp, whether it be dentalcorp or the regulatory authorities or the associations, they're all trying to guide members and registrants, etc., as best as they possibly can in a very difficult situation. So we want to be informing the community, the dental profession across the country. So as soon as we start to get results, we'll be letting people know so that they can, hopefully that can inform decision making around guides. So there's a rough, quick resume of what we're doing.
Those are three, so I counted three distinct sort of buckets that your projects fall in. I think all of them are interesting and relevant. And so I'd like to go through each of them. I'm going to start with your survey of Nova Scotia dentists. And I'm just curious to know, what were the findings in terms of you know, their feelings around providing dentistry, their level of anxiety, the precautionary measures they were taking, and things of that nature. What did you learn through your survey?
So it was very interesting. We got a really good response rate, as I mentioned. We got 43% of all the dentists. It was sent to all dentists, and 43% responded. And we found what was really interesting. We were trying to focus on how many were providing in person care. Recognize that in Nova Scotia, it was very carefully controlled. There were only, I believe it was 8 clinics where there was in-person care being provided. So that's obviously different from other provinces where different approaches were taken. But it was very interesting to see that there were a very large number of people, dentists, who were actually providing care. So amongst our respondents, we had 95% of them had provided some sort of care. Obviously, there was actually only, I think it was 13 dentists of the 200 or so, 250 or so that responded, that were providing in-person care, but 95% of the dentists were providing care using mainly the phone. Some were using FaceTime, but the vast majority were using the phone, which gets into the, you know, the other element of one of the other projects I was talking about, the whole concept of teledentistry. Okay, that's a much bigger topic, but I thought it was very interesting to see that so many dentists, and I'm sure it was the same across the country, and I'm sure Gary was heavily involved in that sort of thing as well himself, rapidly moving to this means of communicating with and trying to help their patients in very difficult situation. So that was really interesting. In terms of the actual care, you won't be surprised. It was mainly advice, triaging, trying to see what was best, prescribing over the phone for antibiotics or painkillers or things like that. The other element to the survey was we asked them, there were some closed questions with structured answers, but then there was an open-ended question where we just wanted them to express their concerns about what was going on. And we had a very high response rate to that question. About 50% of the respondents responded, and they were talking about sort of these categories of concern for their health and the health of their staff, for obvious reasons. I think everyone at the beginning, remember, this was in the middle of April, so we were really in the peak of how things were going up in terms of the epidemiology of the disease. And they were very concerned about their health, the health of their staff, the health of their families. They were very concerned about the well-being of their patients, because they were really worried about the fact that, and at that stage, no one really knew when they would be opening again. They were very worried about access to care issues. How were they going to get their patients in? They were very concerned about the fact that they were having to compromise care by prescribing antibiotics or painkillers when they knew that was really not the best way to be dealing with it. They were worried, very understandably, about the future of their office, of their practice, of their business, which is very understandable. Dentistry is basically a small business enterprise for many dentists, and that's a big concern. And I'm sure dentalcorp had its own concerns on that level as well. And they were concerned, the other big area was concerned about communication between dentists and the regulatory authorities, dentists and the government. There were lots of decisions being made, and clear communication was very difficult. I think they really appreciated what the regulatory authority was trying to do, and they understood the difficulty of the situation, but I think there was a lot of concern about having clear information. For instance, what they were asking, why is it that dentists were being very closely limited on what they were doing, while many other healthcare providers, physicians, were continuing with their healthcare provision? Of course, we have to recognize that many physicians had to stop. Oncological surgeons, heart surgeons, many forms of surgery were stopped for 2 or 3 months. They're now getting going again. But so there was lots of forms of healthcare that were actually ceased. But I think dentists
you
felt
raise
a
an
bit
interesting point.
left out on a limb.
You raise a really interesting point and observation there. I think a lot of dentists had that feeling of being excluded from the family of medicine, even though we are a specialty the same way. An eye doctor, an ENT, a bone doctor, orthopedic surgeon is a specialty of medicine. But you're absolutely right that, I spoke to a couple of doctors who work in hospitals, and they said it was really only life or limb surgeries happening. And so your orthopedic surgeries, knee replacements, hip replacements, those physicians were in many cases idled, or they were redeployed in some other fashion. And so maybe just not being considered for redeployment was part of the reason that dentists felt somewhat excluded from the family of medicine, which I think is, part and parcel of our system, where dentistry is in large part fee-for-service. It's not necessarily covered by OHIP to the extent that some other categories of medicine might be, but extremely, extremely interesting. And you mentioned there are a couple of interesting things that in April, dentists were very concerned about their patients, about the safety of themselves and their staff. I think those concerns are still there. And they've just sort of evolved over time and changed a little bit in the way that that's expressed. And I know, Gary can speak to what that experience has been like clinically. You've been practicing, Gary, basically since, day zero. And I imagine you've had staff and other partners, other dentists who've been concerned about their health and their well-being. How has it been managing that level of anxiety and concern?
Yeah, the first couple months was, as everything, a lot of uncertainty. And as as time marches on, we're a little more certain. Certainly, we still have a lot of uncertainty about the virus and how it's transferred, asymptomatic, symptomatic, this, that, and the other. But we were very vigilant, of course. And I guess there's human nature tendency to ease up your own way of practicing. But this is a time when we have to be as vigilant as we were when we started in March and April and May and so on. And we are. And we're really concerned not only for our own safety, but even more so for our staff and, of course, our patients. And it's perception that takes the majority of the issues with our patients and our staff. So we're as vigilant as we were with respect to our precautions, the protocols of our practices, to ensure the safety and the well-being of our patients and our staff, and of course us. So we are as concerned as we were, and even more concerned because we don't want to see things go backwards again. So we have to maintain it. We can't be complacent. And like I said, we have to be as vigilant as we were in the beginning, and so on. And as Dr. Allison said, who knows when this will be over? It may never be over. And if this particular issue does subside, then there'll probably be another one. And I think we're all prepared for the next one, whether it's COVID-20, COVID-21, or have you. I mean, we've gone through HIV, we've gone through MERS, we've gone through SARS, and now we're going through COVID-19. And this is just the reality of it. And things are changing, and we have to be aware of it and cognizant of it and protect ourselves, our staff, and our patients.
Yeah, and you're absolutely right about not being able to let your guard down. It's like as soon as you feel that you have things under control, all of a sudden you get a call from public health saying, I think one of your patients that was there a few days ago had COVID-19, and they're asking you about all of your precautionary measures that you're taking and all of the controls that you've put in place. Maybe Dr. Siqueira, there's a number of questions I want to get to later with you, but I know that you're also intimately involved in the University of Saskatchewan College of Dentistry's clinic, which the students participate in to get some important experience. How is dealing with COVID-19 affected the university's dental clinic, and what's changed over the last couple of months since the last time you and I checked in on that?
Yeah, so changed completely from March to now. Basically, our clinic is changing every 24 hours. We'll have a different protocol and doing adjustments in the infrastructure of the clinic to accommodate all the requirements from the dental regulators that we needed to accommodate. And just to come back about the anxiety, and it's interesting because we have one specific study that we are conducting, and we have a survey that is about the anxiety and the information that dental students and faculty members from Canada and from United States. So we got more than 1,500 replies, and we are now make the statistics to understand. And basically what the direction of the data is showing for us, that is based on more information that the students or the faculty members, and in the case of the dentists, know about the disease, because this is a very new disease. It's only 8 months that we know about this disease, starting in December, November in China, and now we are in July. So we are learning the day-to-day how the disease progress and what is the behavior of the virus in the body. And we started to see in this survey that is more and more that the people has more information how is transmitted how is the transmission of the virus more comfortable. The people are to come back to the clinic and follow the protocol, that infection, the prevention control protocol that is the schools are applying. So this was very interesting to see this in our preliminary data. But our students are become more comfortable with the new dentistry that is we needed to have after this COVID-19 situation. And last week we started to have some courses that return. So we have our oral oncology program that started, and we have our international training dentistry returning to the school. And August 4th, now we go to have the full school back. And more and more information we need to provide, not just for the students or for the faculty, but also for the patients, because there's a lot of patients, and probably in the private practices happen the same thing. The patient has some anxiety and fear to go to the dental office, because everything that is in the news now, that is dentistry is and dental hygiene is in the top of the transmission. That is in some extent it's not totally true, because if we follow the infection prevention control that the dental regulators are applying, we are minimizing, we are reducing the risk of transmission.
That's a great point. This is a very, very new disease, and for some people, I think it's felt like we've been in the middle of this pandemic for decades now, and yet it's 8 months. We don't know what happens 9 months after you get COVID-19, because nobody's had it for 9 months, and if there are long-term consequences, whether pathogenesis or whether to the immune response to having had COVID-19, we really don't know. So every day we're learning something, and just when I feel personally that we can take things for granted, all of a sudden it changes. So we've had these conversations about herd immunity and things like that, and then there's a wave of news articles saying that you can get COVID-19 twice. So we're constantly on the edge of our seats, and I think we have to appreciate that our doctors, our students, our patients, our staff are also basically in the middle of a roller coaster, and we have to communicate with that in mind. And in terms of communication, and communicating with patients in particular, the role of virtual dentistry has really grown, and the interest in teledentistry has skyrocketed over the last 8 or 9 months. But as patients start to get, Walter, to your point, more comfortable, and as staff get more comfortable, I think a lot of people are forgetting maybe that that's an option, which is problematic because, you know, to prevent a second wave or to prevent an outbreak in an office, we really need to do everything we can to minimize the possibility that some of COVID-19 is there. And so that's where I think teledentistry has a lot of value that we're starting to understand, but maybe is still untapped. So I don't know, Paul, if you want to share a little bit more about your interest in teledentistry and some of the research and exploration you've done over the last few months, I think that would be great. Oh, you're on mute, so it's not on mute. That's the classic.
Thank you. Sorry about that.
Involving
That's a learner error. Sorry about that. So yeah, as I said, you know, when we did the survey of the profession across the country, this came out as a big area of interest. So a few of us started looking into it, and you know, as I said, when we looked at the literature, there's actually not been very much research in the use of teledentistry in the field of dentistry. I think it's been used much more in telehealth, telemedicine. I mean, to some extent, I understand that. Why, you know, clearly dentistry is very much an in-person, hands-on field, essentially a surgical field. So it's going to be very limited what one can do when you're not doing in-person care. That said, clearly in this particular situation, we need to explore how we can use teledentistry. And when I say teledentistry, I don't just necessarily mean Zoom or FaceTime or these video conferencing means. I mean all forms of communication, or like I mentioned earlier on, all those Nova Scotia dentists using the telephone. So I think, you know, telephone is part of teledentistry. One could even say email is part of teledentistry. So these forms of communication which are not in person, I think are very important to explore for the obvious reasons of trying to reduce contamination, reduce risk for everyone concerned, the patients, the staff, the dentist, et cetera, et cetera. But we need to explore what is the best technology to be using. We need to be very clear on what teledentistry can and it cannot do. So some things are very clear. Clearly, you can't do a filling by teledentistry, but clearly you can ask questions to triage risk, to triage how is the patient doing. You can do follow-up appointments by teledentistry, asking certain outcomes. So there's certain things you can do, but then you start to get in, there's a gray zone around things like, can you do screening properly to screen for particular problems? And that's the sort of thing, there's areas of gray areas where I think we need to do proper research to evaluate what can and can't be done in a valid way. And I think we need to think about this not just because of the pandemic and as we've been talking about the fact that we have no idea how long this is going to be going on. But I think even when we get to the point in the future where, let's say, we have actually moved on from this pandemic and gone back to some sort of normal, it's a great opportunity to use teledentistry to try and address some of the issues of access to care. I think, you know, there's lots of people who could actually, there's lots of situations where we could actually be using it to improve access to care. The obvious example is in rural areas where, you know, you could get on Zoom or FaceTime or whatever with a patient and help to come to some decision. Is it worthwhile them driving 300 kilometers to come and see you as a dentist? It may not be, and it may be, and it's you know, again, recognizing the limits and exploring that sort of thing. It may be really good opportunity for working with people like Gary, the specialist, a generalist in a rural area, getting some advice. You've got the patient with you, you've got the radiographs, you can get an intraoral camera, you can have quite a sophisticated interaction and consultation between a generalist and a specialist, between you know, quite a remote or rural area. And again, it doesn't even actually have to be rural. It could be, you know, there could be patients in the same city, in the same town, who for whatever reason don't want to travel, can't travel, and this may help the care. And I think we can view it as ways of maintaining the communication with our patients during pandemic. I'm sure Gary will talk about patients who need care but don't want to come to the dentist. They're fearful for a good reason of coming to the dentist. It's just normal. We've been talking about anxiety, and I think everyone's anxious about what they can and can't do. So if we're able to put off treatment for a few months and engage in a conversation with patients to maintain the interaction, make sure they're doing okay, so you genuinely can put it off for a few months and then get them back in later on, then I think there's all sorts of things we need to think about. We also need to think about things like consent. If we are going to make this more formal, then the patient needs to understand that this is actually a formal interaction and they're consenting to any information they give to you, just as they would do when they're in interaction in the dental chair. So there are a number of issues we have to think through, but I believe, and I'd be very interested to hear what Gary's got to say that as a practicing dentist, that
Julian,
there are opportunities.
I'm interested in one aspect. I know some of the doctors that were on our emergency teledentistry line over the months that everybody was closed. Everyone was more often than not fearful of the liability that they would incur if they did something wrong, and what is the right protocol, and what records do we keep, what records don't we keep, what records do we have to keep in order to maintain our compliance with our different provincial bodies. So maybe you can speak on that, Julian, because that's your area of expertise.
Yeah, so we had a number of dentists. Gary, you were active on teledentistry. All across Canada, we had dentists who were involved in various forms of teledentistry. And the fear of, I think the unknown is really what it comes down to. Not the virus this time, but of the modality of treatment. And I had a lot of dentists ask me, is teledentistry covered by my malpractice insurance provider? I consulted with a number of other lawyers who felt that it would be, and I think some of the regulatory colleges clarified that by stating explicitly in their new and improved teledentistry standards that teledentistry is the practice of dentistry. So Gary or any other practicing dentist who has malpractice insurance for the practice of dentistry was now very clearly covered under that. That said, obviously there's a risk and there's a discomfort for dentists who are used to having the patient in the chair, who are used to being able to look at, touch, feel, and explore everything with their hands, to take x-rays, to take pictures, to literally probe the area of concern, to all of a sudden be saying, can you take a picture of your wisdom tooth? When you may have limited opening and it's dark and they've got basically they're using a phone camera, and then you're asked to, is this a situation where you can provide a controlled substance or a narcotic which may potentially have, adverse consequences of its own? Or can you prescribe antibiotics, which, obviously we know people can have sensitivity, allergies to adverse reactions such as, C. difficile. So dentists were, the ones that I were advising had a lot of concerns. And I think most of them had to do with the fact that it was something new and different. So far, there hasn't been any unusual activity in terms of lawsuits or complaints relating to teledentistry, but I completely understand, where that was coming from. So,
I think we're evolving now, Julian, with respect to teledentistry, where, I see now, obviously, we're not getting as many calls on the emergency service because dentists are open, and many of our own practices within our network are setting up their own virtual care platforms where the patients can speak to the dentist over video, chat, text, as Paul said, email, so all comprise it. And we're using teledentistry, to communicate with our staff every day, the ones that haven't come back to work yet, and explaining to them what's going on and keeping them in the loop, which is important. And not only are we answering questions about emergencies, but also new procedures that are available too. And this is a great modality for dentists, just generally, to talk about, the beneficial effects of whitening and aligners and, sleep appliances. So it's a good avenue to discuss other things other than emergencies. And as Dr. Allison said, great for screening and also for helping colleagues. I think a day doesn't go by where I get an email, a text, or even a FaceTime call from a referring dentist, or a dentist that hasn't referred, someone that may be out of my locale and far away, and they have a question. How do I deal with this? How do I deal with that? And of course, like you said, and like Dr. Allison said, nothing like being hands-on, but it's the next best thing to being there. And I think as we evolve, I think teledentistry is going to take a really a large part of our practice, because we've already seen it in its intensity, and now we can branch out from there.
I'm fascinated by, honestly, the possibility of the general dentist to specialist referral becoming so much more immediate, A, and B, so much more informed for the specialist who's being consulted. That's something I haven't seen. I honestly, Paul, I haven't thought about it, but particularly for dentists who are in more remote, rural areas, to be able to have the specialist almost looking over your shoulder, and to answer questions and to tell you what questions you should be asking the patient and what you should be looking at is, I think, a completely untapped area for dentistry, and an opportunity for an incredible
Absolutely.
amount of collaboration. And quite frankly, that would, I think, facilitate a lot of learning and development for general dentists. And it would also give specialists the ability to reach a lot more people with their expertise.
Absolutely. I mean, I think, because it's not, yes, of course, it will be between the generalist and the specialist, and not necessarily just between colleagues. It may be between two specialists, between generalists, whatever. But the other thing is you can end up having a three-way conversation involving the patient. The patient can be there in the chair with one of the practitioners, and then there's the other practitioner online on a video conferencing, and with today's sophistication of imaging, there's so many possibilities, and you can have the discussion. The patient can ask the specialist at the same time as their own family dentist, and they can engage in a real three-way discussion to come to the conclusion about what's the best way ahead for that particular person. So I think if it's explored in that way, it's a real benefit for everyone concerned: the patient getting the best care, the general dentist, and the specialist being linked into this sort of more family dentist approach as well.
So basically, Paul, this is what we are planning to do here in the dental school. So basically, we go to have an intraoral camera, and also in each student, we go to have a kind of a GoPro camera. And instead of the professor to go in the aerosol procedure area room and needed to change the PPE every time to go from one room to the other, the professor go to communicate with the student by using the camera, and they go to guide the students in the procedures using this technology. So what you're talking about can go in this direction too, and communicate and maximize the time of the patient and the clinician and the specialist by reduce the number of appointments.
Walter, I have a question for you. Is your clinic open concept like the University of Toronto?
Yeah, every dental school is an open concept. But we are doing adjustments in the infrastructure here, so we go to have close to 20 rooms. That is, we go to have walls that will be specific for aerosol procedures. And these rooms, the students will be using intraoral camera and the extraoral type of camera that is for the faculty members to guide the students in the procedures.
Fascinating.
And of
That's
course, this
amazing.
approach could be used in continuing professional development as well. I guess. I mean, I think we need to, we need to explore it again to see what extent our perception using a camera is as good. Clearly, there's limits, but I mean, what can we really see okay, and what can we not see okay? Whether it be in a teaching concept or in a care context or whatever.
Absolutely, you are absolutely right. Especially that country like the size of Canada, that is, we can have a live surgery happening here in Saskatchewan, and the dentist in Quebec watching, and the same thing here in the province of Saskatchewan. That is, we don't want the patients or the general dentist that is working 3 hours north to have send the patients for a specialist here. So this type of teledentist can facilitate the communication between specialist and the dentist.
Honestly, this is it's exciting stuff. Like, if you think about it, dentists remotely can have access to X-rays, to CBCTs, to medical history, obviously to the chart notes. They can have access to live cameras, access to 3D images, to scans, and can, while their hands can't necessarily be in the patient's mouth, although robotics is maybe a conversation for a future webinar, they could really be there. All of their expertise and knowledge can be in the room with the patient without having to get on a flight, go through the airport, rent a room in a hotel, spend a few days doing surgery or endo, and take all that risk of traveling from maybe a city where there are high rates to a town where there's zero COVID-19. Which we're seeing in Canada. That does happen in small towns that are off the beaten path. You've got surgeons who have a particular skill and expertise who go through all of the rigmarole of traveling. And my goodness, the value of time, spent in an airport or in a club lounge or whatever it is providing care to patients. I don't know that it makes sense when you can do everything but perform the surgery. Using prudently and judiciously teledentistry. So I think just a fabulous opportunity, and not only one specialist, you can have multiple specialists, radiologists, working for a patient remotely, spending a small fraction of the time when you take out the travel that would be involved, and really having a huge impact. So I hope that dentistry moves further down this path, because it is extremely exciting. There's a lot of opportunity for access to care, for professional development, for quality of care improvements. So I hope regulators see the potential in teledentistry. I hope dentists see the potential in teledentistry, and I think we're going to need to develop our own software as well. There's teledentistry. Telemedicine software that's been around for a few years, but there are very few proper teledentistry platforms that are set up for the kinds of things that we're discussing now. But I think as they hit the market and become more user-friendly, it really will open up a lot of opportunities. I'd like to shift a little bit the conversation, just because there are a couple topics I really want to touch on. And I don't want to miss them. So I want to jump to a June 29 CBC article that my Google Alerts sent to me, entitled "Saliva Test to Detect COVID-19 Being Developed in Saskatchewan." So let me just say that I have been asked 100 times by dentists and practice managers and hygienists and dental assistants, when will we be able to have quick reliable tests that we can use to screen our staff and our patients, you know, we would feel a lot safer if we were able to do this. There's concern about asymptomatic transmission. You know, we can screen our patients till the cows come home, but if people can transmit the virus asymptomatically or pre-symptomatically or parasymptomatically, that's not going to help us. When will we be able to test our patients? Walter, you know, the photo on the front of this article is of you. I'm not sure where you are, but talk to us a little bit about the COVID-19 test that you're working on and where you are in your research and when we might be lucky enough to have access to that.
Sure. Now I become very excited to talk. So, as my background as a dentist and PhD in biochemistry, I work with saliva since I was undergraduate student in the dental school. And when the COVID-19 started, I stopped completely my lab, and all my graduate students started to working in a technology that we created 3 years ago for a Zika virus infection, where we identify the proteins and the peptides of the virus instead of the RNA and the DNA of the virus. And we are modifying this technology for COVID-19. So basically the big advantage of this technology is that the protein and the peptides in saliva is more reliable and they survive for more time than the RNA and the DNA. So this means that if you have the virus and the method to go to detect the RNA of the virus or the DNA of the virus, depending on the disease, you have a window to detect that before the salivary proteins to cleave this RNA and DNA and disappear from the oral cavity. But when you go and search for the proteins of the virus and the peptides of the virus, the window of detection increases because it's more difficult for the salivary proteins to cleave these peptides and these proteins. And the amount of the peptides and the proteins is significantly higher than the RNA. So this increases also the detection method. So instead of go for attomol, you can go for nanomol methods. So our lab now is in the process that we got funded from the Canadian from the CHR and this is 1 year grant. And our lab now is basically collecting samples, and we have the partner of the Saskatchewan Health Authority for that. So all the patients, that has coronavirus here in Saskatchewan is being advised about this study, and if they want to donate saliva, we create a kind of a system that we go in the home of the patient and collect saliva there. And our research now is in the stage to identify what is the potential biomarkers, peptides and proteins of the virus that is always present in every sample. And after that, the next step is to make a synthetic peptide, synthetic proteins, and put this in one point of care device that will be very similar to a pregnancy test. So basically this is the idea. And our preliminary data that we submitted when we apply for the grant showing that we have some peptides from the coronavirus that is identified in saliva, and all the samples that we collected, these peptides is always there. So this means that now we just need to increase the number of samples, because in this field, we wanted to have a point of care device that has high specificity and high sensitivity. So we are being very careful here to say that this peptide X or Y or Z is the biomarker. So we are not going to use only one peptide. We go to use a group of peptides. So in this way can increase the specificity and sensitivity. So I'm working together with a collaborator.
I just want to jump in, just for some people who maybe don't fully understand the difference. So what is sensitivity when we're talking about a virus test?
So basically, this is very important in a simple way to explain for you. Is basically, this is very important to avoid false positive and false negative.
Mm-hmm.
So the way that we do is because is not to use one single peptide as a biomarker, but to use a group of peptides. So this means that if in my saliva I don't have the peptide A, I can have the peptide B, C, D, and F, and in this way I am be able to say that I have coronavirus or I don't have coronavirus. But in your saliva, if you have the peptide A but don't have the peptide B, but you have the peptide C, D, and E, this is also, I can say for you, you have the disease or you don't have the disease. So this is what we are working at the moment. And this has a lot of bioinformatics involved on that to see what is the potential biomarkers for coronavirus using.
So we're talking about just
peptides.
In layman's terms, I'm a lawyer. I know everybody else here is a doctor and went through dental school and had a lot more biology and microbiology and physiology than I did. First off, so it sounds like what you're saying is if there are certain combinations of peptides present in saliva or proteins and peptides present in saliva, you can be certain to a degree that is acceptable for these kinds of tests that the person either is positive or negative for coronavirus. I think most people understand more or less what a protein is. What is a peptide?
So peptides are the small parts of a protein. So a protein is formed by several peptides. So one protein is formed by several peptides. And a virus basically is a protein. So a virus has a structural protein that is the external part and has the no structural protein. And in our technology, we are able to identify if the virus has this structural protein and no structural protein. And this is very important to differentiate the structural and no structural. Because when you have identified the no structural protein, this means that the virus is infected in the host cell, that is the human cell, and is duplicating, is multiplicating there. When you have only the structural proteins, means that the virus is not infected yet. So our technology is able to identify both, because we are using a very sensitive technology for that.
That's exciting. And I have another question. So we can tell if the virus is amplifying, is reproducing, has infected a patient. So one thing that I've been hearing about is that people can be testing positive for weeks. So, you get the virus. At first, it's below the point of detection. So you'd have to have, your viral tests are not yet sensitive enough to detect it. Eventually, you get to a threshold where, your typical PCR test can detect it. So it's in the threshold of sensitivity. And I don't know if your test that you're working on is going to be more sensitive or less than the PCR, which is kind of the gold standard, the polymerase chain reaction test. But then afterwards, infection can be over. The virus has been eliminated by your immune system, your T cell response, whatever it is. But people are still testing positive because the PCR is testing for RNA. And so even if your antibodies and T cells have gone in and torn apart the virus, if the RNA is still being shed, you're still testing positive, sometimes 8-9 weeks after symptoms have passed. So would your test be able to differentiate what stage you're at? So you're saying you can tell if the COVID-19 is actually infecting, invading cells and replicating. Can you tell if you've moved past that point and now you are shedding and it's just RNA, it's no longer replicating or active virus? Is that something that might be detectable through your test?
Yeah, this is not the major goal of our project, because our project is basically to have a point of care device, but everything depends here how is the behavior of this disease. We are learning every day more and more how the virus is inoculated in a cell and where is if this virus is located in the oral cavity, in the mouth. And it's possible, but at the moment, this is not the major priority in my lab. This everything depends what type of peptides and proteins that we can identify in the way that we can say that is you have the disease or you don't have the disease. But of course, if you identify the non-structural part, this means that the virus is still infecting, and of course this depends of the viral load, and this is what is being shown in the publications, that the viral load of the virus depend of the number of days that you are with the disease, because it had reached a peak and after that you started to have a decrease of the number of virus. And but it's difficult to say for you a straight answer, because we are still learning about the virus. So I don't want to say something here that is not true, because every day we are learning more about this virus and where is this virus is located in the oral cavity.
So that's extremely exciting, and I can imagine, for Gary and other practicing dentists, being able to have a point of care test and to know definitively whether someone has a level of virus that could be transmissible would be a huge relief to not only the doctors who are there, but all of the staff and patients, quite frankly. Again, I'm not trying to hold you to any date, but just give me a timeline of if you're feeling optimistic today, when this might get approval, I guess, from Health Canada, and then, when you start actually testing this in the public, and when it might be something somebody can go to the drugstore and buy.
So basically, my collaborator from the School of Engineering from University of Western Ontario will establish a timeline that is March. We go to have the first prototype to start to be tested, and for this period from now to March, basically the idea is to increase the number of proteins and peptides, and synthesize the proteins and peptides that are potential biomarkers, and transfer this to a point of care device. But another very important aspect that I'd like to mention here, that we are studying, and this makes me very excited and proud of my group, is to identify where the virus is in the oral cavity. If it's in the salivary gland, if it's in the oral mucosa, if it's in the tongue cells. So we are studying where the virus is in the oral cavity. So we are using an animal model. We are using ferrets for that. So ferrets from Vido. Vido is a center here in the University of Saskatchewan that is working in the vaccine. And we have a collaboration with them in terms of to take the salivary glands, to take the oral mucosa, to take the tongue and the other parts of the oral cavity and see if the virus is present in these tissues, in these cells, and if the virus is with the no structural part and the structural part. If it has no structural part, no structural proteins, means that virus is still alive and is still duplicating. So this is very important for us in terms of how we go to work in the prevention of aerosol, how we go to target the aerosol procedures. That could be a mechanical and barrier, or could be maybe using different drugs or different chemicals that can inhibit it. For example, if the virus is in the salivary gland, maybe during the procedure we can use one saliva inhibitor that reduces the salivary flow, and in this way can reduce the aerosol, something like that. So it's important to know where is the virus for us to start to work in different methods to reduce the aerosol in the dental clinic.
Walter, I have a question for you. You're identifying the peptides and the proteins per a particular virus. Is your testing in your studies, can you classify the different viruses other than COVID-19 that may exist in a patient's oral cavity as well? You know, you go to a pharmacy and you pick up you can get a over-the-counter drug test, and it'll classify whether or not you have this drug, that drug, or this drug. Will it be able to say you have this virus, and this virus?
Oh, absolutely, absolutely. Our technology is very specific for coronavirus or Zika virus or herpes virus or HIV. So for example, HIV, you can go for any drugstore and in Canada or US in 1999, you can buy a saliva test that will tell you that you have the HIV or not. And basically they use it to identify the peptides of the virus. And our technology is very similar to that, because we don't want it to, basically what we are investigating there or is not there, yes or no. And every virus, every bacteria has a very unique sequence of proteins that is almost similar to a fingerprint. So we can clearly identify that this is coronavirus, SARS-2, and not other type of RNA virus. Yeah.
If I may, I think this is really interesting work, but I think we need to, and it's really essential to be doing this sort of thing as we're trying to understand this disease and how it's affecting dental practice and how many people in dental practices are affected, etc., whether it's the dentists, the staff, the patients. But I also think we need to start looking again further ahead about how are we going to use the results of the test. If someone's negative, are they really negative? If someone's positive, are they really positive? And what's the implication? Does that mean we change their care because they're positive versus negative? Or do we go the route that we did back in the 80s with HIV, and we move very much to universal precautions? Now, we went in that direction at that stage. Are we going to go in this direction, taking on a whole range of new approaches to deal with the aerosol generating procedures, in which case the test becomes useful for some things, but it's not going to be used for a dentist to make a decision about care or not. They're simply going to go ahead anyway because they've got precautions. So I think we need to start thinking about those issues. I don't know the answer at this stage, but we do need to start thinking about it.
That's a great point, and honestly, it's one that's extremely prevalent because, you know, our practices and practices across Canada, across the world, quite frankly, are screening patients And, you know, you ask a question like, have you been around someone who has COVID-19, or have you been in the presence of a COVID-19 cluster? And of course, there are people who are always going to be answering yes to that question. So what do you do in those situations? You can't defer their care forever. So, you know, my wife, for example, she works at a homeless shelter where it's extremely difficult to control the virus. And once it's in, it's hard to get rid of it. And so, you know, does that mean that she can't get dental treatment, or she has to spend more? She has to pay more because she has to pay for the PPE of the provider, or does she have to go to a specialist who has an AIRR room? Or are we going to get to a point where we understand how this virus spreads? We understand what the actual risk is to the dentist, to the dental assistant, to the receptionist. And I think actually the two of you are working together on a project that is designed to understand better how dental offices' infection prevention control measures are working, and what the risks are of aerosol generating procedures versus non-aerosol generating procedures. So maybe, Paul, you can talk a little bit about the
Sure.
upcoming research and maybe how people can get involved who are interested in helping add to the evidence base in dentistry.
So yeah, as I briefly mentioned at the beginning, this was one, you know, everyone's asking the question, what is the risk for dental personnel, whether you're a dentist, dental hygienist, dental assistant, and the answer is we simply don't know. I think Gary made a good case, and I've heard it plenty of times before, that maybe dentists and dental staff are actually at reduced risk compared to the community, because the infection control measures taken within dental practices are very good. Dentists are very, very good at infection control, generally speaking. So maybe that's going to be sufficient with the other additional measures that have all been promoted. But we just don't know the answer to that question. So, and it's a really fundamentally important question to ask, research question to ask. So, you know, me coming from my more public health background, Walter coming from his saliva research background, and then we're working with a few other colleagues as well, both at McGill and U of T and Dalhousie, as well as U of Saskatchewan, where we asked that question, we sought the funds, and we've got the money to do it, and we're about to launch the project. So in most of the provinces across the country, we'll be working with either with the association or the licensing body, or in one province we'll be working with a dental school through their alumni, and we're going to be trying to recruit at least about 500 dentists across the country. And we're going to be sending those who want to participate. They'll answer questionnaires on a monthly basis about the treatment they're providing, the sort of infection control procedures that they're using regularly, the number of patients they're seeing, and procedures, that sort of thing. But also, this is where Walter's group comes in. We'll be sending them saliva collection kits, and they'll just take a simple saliva sample and then and mail it to Saskatoon, where Walter's team will be analyzing that. So we'll be looking at where basically trying to get a handle of infection rates amongst dentists in the community as we move forward, to see, are they the same as levels in the community? We're working with public health agencies in each of the provinces as well to get accurate numbers on community rates, because just because a dentist in our project gets infected, does that mean he or she was infected through the dental clinic? No, it doesn't. That person may have been infected in the grocery store. So we need to be able to see what the local rates are in the community and compare them with rates amongst dentists. Are they the same? Are they increased? Are they decreased? And to look at also, we're particularly interested, for obvious reasons, at the use of particular masks and the use of aerosol generating procedures. So we want to see if amongst those dentists using more aerosol generating procedures and those using N95 masks, to see if that makes any difference. And we'll be doing this through a year. So we gather data on a monthly basis, both saliva data and questionnaire data. And we'll be doing analyses every 2 months, because we want, as soon as we get enough data, we want to start doing the analyses. We want to be a kind of a live research project, and we'll be communicating the results to all participating dentists, and also to the different organizations that are working with us to help recruit those dentists. Because as I said at the beginning, it's really important that as soon as we can start to see some results, that gets communicated to the participating dentists and the dental organizations, and also to the broader community, so people know whether what they're doing is right, or do they need to take more measures, or in fact maybe they're reduced rates, so they, we can think about what else do we not need to be doing, sort of thing. So
it's funny because I don't know what the results of your research will be. It may be that going to the dentist slightly increases your risk of getting COVID-19. Maybe not, it might not even be statistically relevant. That's possible. But on the other hand, it could be that the rates of transmission in the dental office are lower than they are in the general community. In which case, I'm not thinking of this from a marketing perspective, you could say, if you go to your dentist, statistically, you're less likely to get COVID-19. I mean, that's a little bit tongue-in-cheek, but it's the most important research that we can be doing right now.
It's very important, yeah.
Health and safety for controlling this virus, for the economics of dentistry to understand this, for regulators to be able to implement evidence-based precautionary measures, which right now there is a huge divergence, and it's not just dentists. We have hygienists and some dental assistants have their own regulatory authorities. We have hospitals with physicians, anesthetists, with nurses and respiratory therapists, and in some cases they all have their own regulatory body. And so we have all of these overlapping, sometimes contradictory or inconsistent infection prevention and control guidelines. And that's the result of not having the evidence that I hope your study will deliver. So I'm curious, what is going to be the format? Is it going to be a daily survey, a monthly survey? How are we going to know how many aerosol generating procedures Dr. Glassman is providing in a given time compared to his peers?
So it's going to be a monthly questionnaire that will be that the participants will undergo, and they can choose whether they do that online or they do it by phone. We can do that by phone as well, teledentistry. And basically we'll be asking them about what occurred in their clinic in the last 7 days. So the focus will be on the last week of care. So we can we've done pilot work on this. And I think dentists will be able to estimate fairly well the numbers of their procedures, the numbers of patients, et cetera, and certainly they'll get used to it. So we'll have a good idea of those sorts of variables. And presumably they'll be fairly consistent in their approach in terms of infection control procedures, whether they're using N95 or whether they're using surgical masks, or if they change that according to different procedures. So we'll be able to get a handle on that. And again, we'll be following these dentists for doing monthly questionnaires and monthly getting the saliva samples sent to Walter. And we'll see what happens over the course of the year. We, as you say, we really have no idea what the answer to this really important question is. So we hope strongly that this is going to make a big contribution to the dental profession in Canada and worldwide.
I think what is nice in this research is basically different of my other research, is that we go to get data and we can discuss this data every month. And this will be very interesting to help the dental regulators, because across the country we have a completely different standard in the infection prevention control. And this can help the dental regulators based on the data that we go to get. And also this is very important because this grant, this project is basically, I think, is one of the first projects that I saw in terms of COVID-19 in the world that is really taking care of the oral health care providers and investigate what is the level of us can get infected when we are working, because the majority of the project is more interesting to see, that is also very important to see in the patient side. Now this project go to see the dentist and the dental hygienist, the dental assistant side that is there from 8 to 5 days a week, and of course the level of transmission could be different instead of the patient that is there for 1 hour.
Absolutely, and it'll be interesting to see what happens, with your information. So Walter, for example, if you get 500 saliva samples and a few test positive, what do you do with that information? I mean, are you contact tracing, or what's your role with those positive samples?
So we go to survey around 500, but we are not going to have this saliva analyzed of 500. We will be close to 50 to 60% of that every month. And when it's confirmed, let's say that is one dentist send the sample to my lab, and the result was positive. I don't have the authority as the government to confirm that this is an official test. So basically, our protocol will be to contact the dentist, keeping of course all the confidentiality, and recommend the dentist to contact the health authorities and to do a official test to validate our data.
So Julian, if I could
really
ask a question, Julian, I think this is interesting to everyone that's watching right now. If and the question that's coming, someone tests positive in the office, and you've got 20 staff members in the office and one test positive, but everyone's been following the precautions of wearing masks and social distancing and doing everything that we're supposed to be doing. What will be the response of public health as far as what happens to that particular office?
So I can tell you what we are preparing here for the dental school. If it happen, let's say we have a professor or a student or a staff that has the symptoms and test positive. So basically, because we have more than 500 people in our dental clinic every day, and we have a pre-clinic and simulation clinic and different areas. So we create a kind of a log system to know exactly where everyone is during the day. So when let's say one person is tested positive and the person was in the clinic, all the people in the clinic will be informed to self-monitor and contact the Saskatchewan Health Authority, and we go to follow the protocol to decontaminate all the area and contact the health authorities. But it's important to have this log system, because otherwise we can stop all the dental school, and it's not everything happen in the same place. So some students will be only in the pre-clinic, in the simulation clinic. Some students will be only in one specific clinic. So we are trying to avoid this connection and the people go from one clinic to the other side, in this way to minimize the risk of to stop totally the dental school if we have one case.
I think it's also really important to respond to your question, Gary, to understand that, yes, we're doing the saliva test amongst the sample, and we will presumably have a few that will test positive, chances are, over the course of a year. But there's a long period. If we're collecting data every month, then there will be other dentists who get symptoms and go and get themselves tested anyway between us getting data. So our questionnaire is going to be asking as well, did they get symptoms? Did they go and get a test? What was the result of the test? Same thing for any of the staff in their office. Same thing for anybody that they live with. So I think, and it's not our role to be saying to the dentist what to do with the result. We'll be advising that they contact the local public health authorities to see what the advice is for any health practitioner in that province or that city. And then they'll be making their decisions based on that, of course. But we want to inform them of the results, but I'm sure that there will be just as many, if not more of them, that are actually getting that become unfortunately positive, will actually get their test result from the way we're getting it at the moment in the community.
Yeah, great points and a really good question, Gary. I mean, this has been coming up a lot across dentistry, and I think in every single workplace, because anybody can get sick, and people go and they get tested, and then the employer has to decide what to do with that information. And so the advice I'm providing our clinics and is very, very similar to Walter's recommendation, which is do an investigation and find out where this individual was. Ask questions like, were they observing physical distancing? Were they masking? Were they practicing hand hygiene and respiratory etiquette? How many people were they within 2 meters of for longer than a few minutes, longer than 15 minutes? And these are the questions that public health is asking. And so, if you're an employer, you're running any kind of business, whether you're one of a dentalcorp office or you're a university or you're a private practitioner, you have to realize that one infected individual has the potential to bring a screeching halt to your business or your clinic or your university, but they don't have to. So if you are enforcing social distancing, if you are logging where individuals are and who they're in contact with, if people are wearing masks and practicing hand hygiene, when you call public health or the health services company, they'll ask these questions and they may say, you're doing everything right. The odds of transmission are very low because you've taken X, Y, and Z precaution. And so everybody can go back to work tomorrow, but you should be self-monitoring. These people should continue to exercise all of those remediation efforts. And if anybody develops any symptoms, they should stay home, they should get tested, they should self-quarantine, and they should contact public health again for further advice and guidance. And so just because a staff member tests positive doesn't mean, it's not the end of the world. It doesn't mean your clinic has to shut down. But if you have a dental assistant who tests positive and the day before she tests positive or he tests positive, you had an all staff meeting in a small lunchroom and you were talking and laughing and you were sharing cutlery and cups and you were there for a couple of hours and catching up, your whole clinic it may be self-quarantining for 2 weeks. You're going to shut down. And at that point, public health might say, oh, geez, this is a big problem. Maybe we should contact all of your patients who have been there for the last 3 days. On the other hand, if people are taking lunch outside, they're social distancing, et cetera, they'll say, no problem. The one employee who tested positive is going to stay home for 14 days. We're going to monitor that. Everybody else, if you develop symptoms, give us a call. Otherwise, keep doing what you're doing. Fantastic work. Keep it up. And so that's been our experience. And we've had a couple clinics who have had to close, unfortunately, for a day or two. But the vast majority of the time, whether it's a patient who's come in, the parent of a patient who's come in, or a staff member who's tested positive, our answer to public health has been, we are not only doing what's necessary, but we're doing far more than what's necessary to prevent the spread of COVID-19. And like you said, Gary, earlier on, it's a pretty safe place to be. you know, because of all the measures we've put in. And I think as, you know, dentalcorp is committed to doing everything we can to make sure that there is no spread of COVID-19 in our offices. Touch wood, so far so good. But we can never let our guards down, and it doesn't matter where you work, you know, whether it's in a supermarket, a university, an endodontic specialist clinic, or a general office. We're gonna have to be vigilant, I think, until Walter's test can let us know, you know, in a matter of minutes, whether we're positive or not, in which case maybe we can let down our guard a bit and have some fun, you know, get close to people that we miss. I would just like to end there. We're almost at 8:30. I just want to thank you, all three of you, for your time. Paul, for your insights, for taking the time to meet with you earlier. And Gary, obviously, for everything you do for dentalcorp and DC Institute. And Walter, for the amazing research you're doing, for your generosity this evening. Thank you so much for joining us and for sharing your information. Thank you to all the people who logged in, who joined us, for the people who will watch the recorded version in the future. I hope you found this informing and engaging, and I hope you'll join us for our future webinars. So from dentalcorp, that's it. Again, Julian Perez, it's been a pleasure to be with you. It's been a pleasure to speak with the three of you. Really interesting stuff, and I'm really excited about the future of research in dentistry.
Thanks, Julian. Thanks, Paul and Walter. Very interesting work you guys are doing, and thank you for your contributions. It's immeasurable. Thank you.
Thank you very much. Thank you, Julian. Thank you, Gary. It was a great pleasure to meet you. And see you soon, Walter.
See you soon, Paul. And thank you, Julian. Thank you, Gary. And thank you, dentalcorp, for inviting me. Thank you.
Thank you very much.
Pleasure.
Good night,
Have a
everyone.
good evening.
Until soon.
Bye-bye.
Bye.